attending this session on airway diseases. I would like to introduce our panelist. Our first panelist is Dr. Javed Khan. He is a renowned pulmonologist of ATU and he is known for his campaign against smoking. If he is here, please sir, come on the stage and join the seat. Our second panelist is Dr. Mukhtar Zaman. He is leading pulmonologist in Peshawar. He is known for his continued efforts in training of pulmonologists and his clinical career. Sir, please come on the stage and join the seat. Our first speaker is Dr. Dermot Rayan. He is working in Usher Institute of Edinburgh University and who has won many awards for his outstanding research. So, please welcome Dr. Dermot for his presentation. Sir, please.
Thank you very much indeed for honouring me with the invitation to speak to you today. I'm afraid the first slide doesn't seem to be showing, but it's just an introductory slide. So getting straight into it, the question is, why do doctors not follow guidelines? Well, of course, there's a lack of awareness of guideline existence, which is less common than usual, a lack of familiarity with guideline content, given that they're very complex, a lack of agreement with what they say, a lack of self-efficacy or knowledge in following the guidelines, a lack of expectation of their succeeding. The old problem of inertia, I've always done things this way, I won't change now. And external barriers, particularly guidelines being contradictory or difficult to follow, and or difficult to use, with patient reluctance, lack of resources and financial restraints, as well as practice restraints and a lack of time. So guidelines generally is poor. Whether you're in specialist care or primary care, written personal action plans are very rare. Home peak flow monitoring is more rare still. Spirometry is only done in 40% of patients attending secondary care clinics, and repeated inhaler technique checking, a very, very important thing, is not done in most environments. So, unfortunately, like Andy Capp, the well-known English cartoon character, we settle for what is second best. Current guidelines create complexity and confusion. The algorithmic approach taken by NICE in 2017 was an absolute disaster. GINA is better and more logical, but still can lead us into many pitfalls. We are threatened with the future of artificial intelligence, but actually, as Professor Laurent Muzelec of the Business School of Trinity College Dublin said recently, artificial intelligence brings a huge threat to people's ability to learn and to upskill. The SIGN-BTS guideline brought a degree of sensitiveness, relying on a clinical table of key symptoms: wheeze, cough, shortness of breath, and chest tightness, allowing us to rank patients to be highly likely asthma, which can facilitate early treatment, the possibility of asthma, which requires
excuse me, Dr. Dermot, please share your screen.
I thought I had shared it.
It's not visible.
Apologies.
The green one, the green one.
Yeah, screen.
Share screen. Green.
Yeah.
We cannot see your presentation.
So it is.
बता देंगे ये ग्रीन वाले को दबा दो, उसको बता दो कि ग्रीन वाला दबा.
Hold on. Sorry about this. I thought
if you could please share, click on the green button at the bottom and says share.
Yeah, I have done that. Right.
Just
Okay.
Just click on this button again.
Can you see it now?
Yes, we can see it now. Thank you.
My apologies, I'll start again. So I'm going to talk about the Jigsaw. First of all, thank you very much again for inviting me and honouring me the invitation to speak to you. I'm going to talk about a Jigsaw approach to asthma diagnosis. Why do doctors not follow guidelines? You've heard all this, and the big thing is, of course, they don't fit in with clinical practice. Guideline adherence is poor, as I've already discussed. and as a result of which we settled for second best. Current guidelines do tend to create complexity and confusion. The NICE guidelines in 2017, for example, are a masterpiece in confusion. The GINA guidelines are somewhat better, but still lead us into certain pitfalls. People are looking at AI to help make diagnoses for doctors, but actually that brings a huge threat to people's ability to learn and upskill, because we don't know what we're looking at. The SIGN-BTS guideline, on the other hand, brought a modicum of sense. It listed a clinical table of key symptoms: wheeze, cough, shortness of breath, and chest tightness. And it allowed us to rank the patient presenting into being highly likely to have asthma, facilitating treatment, raising the possibility of asthma, which requires further investigations, and having the unlikely diagnosis of asthma, which means we really need to pursue a different diagnosis. Overdiagnosis is extremely common. In the UK, in a community clinic, 43 out of 43 patients referred with definite asthma to the clinic, only 62% did not have asthma, only 1/3 of asthma. And those with a suspected diagnosis of asthma, 88% did not have asthma. In Canada, reviewing patients who have been diagnosed with asthma in the last 5 years in primary care in British Columbia, over 600 patients who complete the study, 33% had no asthma, of whom 28% were completely asymptomatic, and rhinitis was the predominant diagnosis. Similarly, in Holland, the asthma diagnostic consultation service, of those referred with a potential diagnosis of asthma, 55% did not have asthma. And this is partly because they're using a single symptom to make up the diagnosis. So why do we need a different approach? The diagnosis of asthma is not always straightforward. There is failure to confirm reversible airway obstruction. There's poor sensitivity to spirometry alone to confirm asthma, mainly because spirometry is largely done when the patient is well or asymptomatic, or has already started treatment. We need to take account of the day-to-day variability of symptoms and the numerous phenotypes of disease. The initial diagnosis of asthma is based on a combination of the presence of characteristic symptoms, i.e. cough, dyspnea, chest tightness and wheeze, with a demonstration preferably of airflow limitation and variability. As it said in Pakistan Chest Society clinical guideline for asthma, relying on a single characteristic for the diagnosis of asthma results in both overdiagnosis and underdiagnosis. We studied the educational needs of over 700 GPs across Europe. We found that although many of them felt they had an adequate knowledge of asthma, nearly 50% felt they had a great and immediate urgent need, educational need. So the diagnosis of asthma is a very big task. Diagnose or diagnosticate, identifying, analysing, spotting, detecting, making out, establishing the disease and identifying the problem is something we do on a day-to-day basis. So we launched an exercise to create a jigsaw in asthma diagnosis to produce a short, accessible, comprehensible aid reflecting medical practice and locally adaptable, facilitating the clinical reasoning. We call this the jigsaw puzzle approach. It is a way of thinking. It is not all-inclusive and therefore doesn't take us down different rabbit holes. It does not rely on all the pieces of the puzzle to be present. Clarity of thought and reasoning leads to clarity of the diagnosis. So when the patients come to us, see us, they come with a whole mixed bag of different symptoms and different past histories and different factors. How do we make sense of these? What could they be? How do we make the picture out of this? So our half-day puzzle workshop carried out at our conference in Malaga 2 years ago consisted of 4 working groups and 2 rounds categorizing jigsaw pieces into building a clinical picture of asthma. The 4 corners were the presentation, the presenting symptoms of the patient, the symptoms in the physical examination, the history with the past medical history, and objective tests. And this process can be repeated and contextualized at national level. If anybody wants to watch a video of the process, it's there on YouTube. Doctors came from a range of countries, from lower income countries to higher income countries, and mostly with general practitioners, but there were some pharmacists and there were one or two specialists as well. So the Jigsaw assignment was in 4 groups, 1 for each category or domain. Team 1 was symptoms, Team 2 examination and investigation findings, Team 3 predisposing factors, and Team 4 precipitating factors. As you can see, this is the way it went, 1, 2, 3, 4, and the second round we mixed the characteristics up to come up with the answers. So all the jigsaw pieces were brought into one whole jigsaw in one group to look for duplicates and gaps. When duplicates occurred, by discussion, they were allocated to the category they were most suitable to be included in. Every single piece had to be argued for inclusion, along the lines of why is this piece included, how is it included, when is it included, and to whom do we seek the information from? How will it influence decision making, how will I find out about it, who would I ask, and is it for everybody? And the same with variability, for example, looking at serial peak flow readings. So we came up with the content domains for the 4 domains. Why is the person going to see you? Examples were tight chest, wheeze, cough, the belief they might have an infection, breathless chest pain, symptoms of physical examination, wheeze, nighttime symptoms, fatigue, chest intolerance, and also maybe finding, for example, wheeze in the chest, Harrison sulcus, highly unusual, or elevated respiratory rate, and elevated pulse rate. The history, including occupation, atopy, smoking, hobbies, and rhinitis, and bronchodilator responsiveness, hopefully, if it was there. And we reckon that a very simple test for bronchodilator responsiveness, if the patient came when they were symptomatic, is to give them a few puffs of salbutamol with a spacing device, check their peak flow before administering the medication, wait 5 minutes or so, and then recheck the peak flow 5 minutes later, because salbutamol is very rapidly acting, and you may get your reversibility straight away. Now, some people like starting jigsaws from the corners. So we look at key pieces in each of the corners, building the picture or assembling information using a problem-solving approach. Sometimes we may find something very, very clear, very, very early. We may have airway reversibility, for example, from the process I've just described, often doing serial peak flow checks, readings. I recognize that peak flows are not always available in many countries. It is cheap, or relatively cheap, but it's a lot cheaper and a lot easier for the patient than doing spirometry. But even if you haven't got these technological aids, as it states in the Pakistan Chest Society guidelines, the picture may be fairly well complete and may be fairly obvious. Some clinical symptoms and signs may not fit the overall picture, however. So, for example, paresthesia would not be something one would normally find with asthma, but it fits in very, very well with paroxysmal, with dysfunctional breathing, something which is becoming increasingly common, particularly amongst female patients, certainly in the Western world. And it can be an alternative diagnosis to asthma, but it can also make asthma worse. And then productive cough. It's rare that asthma produces any significant symptoms, so productive cough makes you think about something else. So pieces which do not fit should prompt a search for another picture or an alternative diagnosis. Once we've put the picture together, we are fairly sure of what the diagnosis is, but if we add in variability or reversibility, we are really sure. Therefore, as it says in the PCS asthma guideline, every effort should be made to elicit detailed history of characteristic symptoms and to demonstrate variable or reversible airflow obstruction in suspected patients having asthma. Making of the diagnosis is absolutely critical, because people who are misdiagnosed with asthma are receiving treatment for a disease or a problem that they haven't got. On the other hand, they may be missing treatment for a disease which they have got, so it could be delayed in treating the underlying cause of their symptoms. The good news is this is published now on the International Primary Care Respiratory Group website. You can take that QR code there if you like, but I dare say the slide set will be shared with you, which should make it easier for you. So asthma diagnosis is a complex but essential task. The management is multidimensional, not just looking at medication, but patient's lifestyle, smoking cessation, and so forth. It's really, really important to engage the patient in this process. And there's a big knowledge and skills deficit amongst healthcare professionals. Thank you very much for your attention.
इनसे सवाल